Hi, my name is Bree Cowart. This is my presentation on oppositional defiant disorder. It is November 14, 2021, and this is for class nursing 7348. By the end of this presentation, you will learn the DSM-5 criteria of oppositional defiant disorder, which I'll also call ODD, the diagnostic features of ODD, the prevalence, risk, prognostic, and cultural related features of ODD, comorbidity and functional consequences of ODD, discuss the differential diagnosis of ODD, and lastly, discuss the treatment options and evidence-based practice of ODD. The DSM-5 criteria includes a pattern of angry, irritable mood, argumentative, and defiant behavior or vindictiveness lasting at least 6 months as evidenced by at least 4 symptoms from the following categories and exhibited during interaction with at least one individual who is not a sibling. So first, they'll have an angry or irritable mood, and this includes often losing their temper. They're often touchy and easily annoyed. They're often angry and resentful. They're also argumentative and have defiant behavior, and this includes often argues with authority figures or for children and adolescents with adults, often actively defies or refuses to comply with requests from authority figures or with the rules, often deliberately annoys others, often blames others for his or her mistakes or misbehaviors. And then there's also vindictiveness. And this is spiteful or vindictive behavior at least twice within the past 6 months. Next, B, the disturbance in behaviors associated with distress in the individual or others in his or her immediate social contact, such as his family, peer group, or work colleagues, or it impacts negatively on social, educational, and occupational areas of functioning. C, the behavior did not occur exclusively during a psychotic, substance use, depressive, or bipolar disorder episode. Also, the criteria are not met for disruptive mood dysregulation disorder. Note, the persistence and frequency of these behaviors should be used to distinguish a behavior that is within normal limits from behavior that is symptomatic. So if it's less than 5 years, the behavior should occur on most days for a period of at least 6 months unless otherwise noted. If they're 5 years and older, the behavior should occur at least once per week for at least 6 months unless otherwise noted. While these frequency criteria provide guidance on a minimal level of frequency to define symptoms, other factors should be considered, such as whether the frequency and intensity of the behaviors are outside of range of a normative for individuals' developmental level, gender, and culture. So what are some more diagnostic features that you may see in practice? In order to diagnose oppositional defiant disorder, it must be observed with individuals other than their siblings because these behaviors are common and normal to have with siblings. For them to be argumentative and things like that. Symptoms may not be apparent in the clinical setting. So when you see this patient, they may not appear like they have this disorder because it's happening more in the home setting. They often do not see themselves as oppositional, defiant, or angry. Instead, they justify their behaviors as a response to unreasonable demands or circumstances. And it's more prevalent with families in which child care is disrupted by a succession of different caregivers or there's inconsistent parenting. So how do we determine the severity of the symptoms? So to be considered mild, symptoms are confined to only one setting, such as at home, at school, at work, or with peers. Moderate, some symptoms are present in at least 2 settings. And then severe, some symptoms are present in 3 or more settings. So that's how you would determine your severity of your symptoms. So here are your stats for oppositional defiant disorder. Your average prevalence rate is 3.3%, so it's pretty low. Males have a greater chance than females of getting this. That's 1.4 to 1, so not much of a big difference, but there is some. Temperamental factors go into play with this. This includes your emotional regulation. If you have high levels of emotional reactivity and poor frustration tolerance, it's more predictive of this disorder. Environment also plays a factor into this. If you have harsh, inconsistent, and neglectful child rearing practices, then you are more likely to have oppositional defiant disorder. And genetic and psychological also kind of plays into this. So some neurological markers such as lower heart rate and skin conductive reactivity Reduced basal cortical reactivity, abnormalities in the prefrontal cortex, and amygdala have also been associated with this disorder. But there is no specific marker which tells us that, this is going to lead you to having this disorder. Also, oppositional defiant disorder does not have a consistent course. Symptoms are often resolved by early adulthood, although other mental health problems, such as mood disorders and social impairment, may persist or develop. Adults and adolescents with a history of ODD have a greater than 90% chance of being diagnosed with another mental health disorder in their lifetime. They are at high risk for social and emotional problems, such as anxiety, depression, bipolar disorder, and higher rates of substance abuse, and as adults, including suicide. Early intervention is aimed at preventing the development of conduct disorder, substance abuse, and delinquency that can cause lifelong social, occupational, and academic impairments. Over cultural, it really does not show a preference on what culture or ethnicity has this disorder more than others. So it's pretty consistent over, across countries with different race and ethnicity. So let's look at your differential diagnoses. So with conduct disorder, the behaviors are less severe with oppositional defiant disorder compared to conduct disorder. So there's no aggression towards other people or animals, there's no destruction of property, and there's no pattern of theft or deceit. With ADHD, you want to determine the individual's failures to confirm to request or others is not solely in situations that demand sustained effort or attention or demand that the individual sit still. So that would be how you differentiate from that. Disruptive mood dysregulation disorder, ODD and DMDD are similar. DMDD is more chronic. ODD is more acute. Look at the severity, frequency, and chronicity of temper outbursts. When the mood disorder is severe enough to meet criteria for DMDD, ODD diagnosis should not be given. So they may first start out with ODD, and then they would progressively, if it continues, the behavior continues, it'll continue into disruptive mood dysregulation disorder. Intermittent explosive disorder, individuals show serious aggression towards others that is not part of the definition of ODD. So, they're not seriously like trying to harm anybody or anything like that with oppositional defiant disorder. Social anxiety disorder, you want to distinguish from defiance to a fear of negative events with social anxiety. So if you want to see what's causing these behaviors, so you definitely want to ask those questions. And depressive and bipolar disorder. ODD diagnosis should not be made if symptoms occur during a mood disorder. So you would, if they had a mood disorder or bipolar disorder, you would diagnose that first. And then after it had resolved, if the behaviors continued, then you can do a diagnosis of oppositional defiant disorder. So diagnostic tools. Right now, there's no questionnaires that are specifically designed for diagnosis ODD, but multiple tools can aid in the diagnosis while assessing for other psychiatric conditions. So one study of the Vanderbilt scale of ADHD found that affirmative answers often or very often to the items actively disobeys or refuses to follow adults' requests or rules and is angry or bitter had good sensitivity of 55% to 88% and specificity 85% and 94% for diagnosing ODD. So what are the treatment options? So there is behavioral therapy, which is your first line treatment that you should use. Parenting interventions is best to be used in younger children, and individual therapy takes a more prominent role with adolescents, but outcomes are better when parents are involved. So you want to try to involve the parent and the patient together to help with these behaviors. Medications are not recommended as first-line treatment options unless there's a co-occurring mood disorder. Then treatment would probably be beneficial. So if they have depression or anxiety, you definitely want to treat that. At first, that could be what's causing these behaviors. And then afterwards, you definitely want to have your behavioral therapy interventions as well, kind of intertwined with it to improve it. Early intervention may help prevent other disorders such as conduct disorder, substance abuse, and delinquency. And that's what we want to work on. We definitely want to do the preventative measures to prevent from further hospitalizations and help them improve, in all aspects of life. So let's talk about the evidence-based practice in therapy. Child-based therapy often focuses on problem-solving skills, whereas parent training, parent management therapy, focuses on how to respond to the child's behavior. Parent management therapy aims to help parents manage disruptive behavior by decreasing unintentional positive reinforcement of disruptive behaviors, to help them understand appropriate consequences and punishments for disruptive behaviors, and to help them make their response timely, predictable, and appropriate. Overall, the goal is for parents to be more positive and less harsh. A 2012 Cochrane review found that group parenting interventions based on behavioral therapy and cognitive behavioral therapy are effective and cost-effective for improving child conduct problems, parental mental health, and parenting skills in the short term. Group CBT for children have also been found to decrease aggressive behaviors. Collaborative problem solving in which parents and children work together is another effective technique for treating ODD. And using both treatments showed a 50% of children no longer met criteria for ODD after 6 months. So it's very effective to use therapy as your number one intervention. All right, let's look at the evidence-based practice for medications. So in this, stimulants can help improve oppositional symptoms in persons with comorbid ADHD. So if they have ADHD as well, this can help. So Strattera had mixed evidence for reductions of ODD symptoms. Clonidine has also proved effective in managing concomitant ADHD and ODD. Antidepressant therapy in persons with concomitant depression and ODD can help both disorders. One study found that Prozac, with or without CBT, improves comorbid ODD. Fluoxetine plus CBT was superior to CBT alone, but ODD symptoms improved in all treated groups. A 2012 Cochrane review found limited evidence that atypical antipsychotics helped with aggression and conduct problems in children 5 to 18 years of age. The evidence was strongest for risperidone, so risperidone helped the most for aggressive behaviors. In practice, we always want to teach and learn about prevention because this can help prevent from these disorders from happening. So it's important to incorporate these things into your visit. So programs that improve social skills, conflict resolution, and anger management in preschool-age children to adolescents can reduce the risk of ODD. These programs are often embedded in existing community programs that serve high-risk youth, such as Head Start, the Incredible Years program, and there's the link. And additional resources can be found at the American Academy of Child and Adolescent Psychiatric website, and here's also the link for that. Here's my list of resources. This is page 1 of 3. Here's page 2. Here's page 3. This concludes my presentation on oppositional defiant disorder. Thank you for listening to me today, and y'all have a great day. Thank you.